Hi, everybody. My name is Anne-Marie Hayes, and I'm a research associate on the Joppa campus of KCU. Today, I'm going to be introducing our speaker, student Dr. Reed. She's in her anatomy fellowship currently at KCU, and she will be presenting on her cadaveric study that she's been completing as an anatomy fellow at KCU. So, to introduce our speaker, student Dr. Colleen Reed is originally from Cape Girardeau, Missouri. She graduated from the University of Missouri-Columbia with her Bachelor's of Science in Biochemistry in 2018. After the completion of her undergraduate career, she accepted a position as a medical assistant for a plastic surgery practice in Columbia, Missouri, where she worked for 2 years before her matriculation into KCU. Her experiences with patients during this time has greatly influenced her interest in breast cancer detection, in addition to women's and LGBTQ healthcare. Student Dr. Colleen Reed is currently serving as a KCU Anatomy Fellow between her second and third year on the Kansas City campus. She currently would like to pursue OBGYN or neurology. So with that, the floor is yours, student Dr. Reed.
All right, thank you, Anne-Marie. Hello, everybody. I hope you had a great Memorial Day weekend. Thank you for joining us on the first day back. So my research project is entitled Development of a Cadaveric Breast Ultrasound Module and Analysis of its Effectiveness among Medical Students. And I had large contributions from Dr. Dennis, Dr. Mark Pence, and Dr. Larry Seegers. Without their help and mentorship, I wouldn't be where I am today in my research. All right. So a little bit about my background and motivation for this research. I worked 2 years as a medical assistant in plastic surgery prior to coming to KCU. During this time, breast conditions had a large impact on me, specifically breast cancer. Patients with breast cancer took a large piece of my heart. It affects not only themselves, but their families. It is a large thing for them to have to deal with. And I was happy to be a step in their process. I feel that it's important for medical students to gain exposure in areas that they might not have access to as a part of their curriculum. 4 years to some seems like a lot, but it goes really quickly. I mean, my first 2 years flew by, and I just want to have access to the full range as much as we can of medicine. If you're going to be doing it for the next 30 plus years, you want to like it, right? Therefore, I wanted to provide an opportunity for medical students to explore breast imaging further. So a little introduction, a little bit about the clinical relevance and literature review before we dive in. So point of care ultrasonography is also called POCUS. That's the shorthand term for that. Handheld or bedside ultrasonography is also another term. It's usually performed and interpreted by the physician. Really gained popularity in emergency medicine, where you can imagine trauma, emergent situations would require faster diagnosis, faster imaging to improve patient outcomes. So it's really revolutionized that area. And then it's also gaining popularity in non-emergency areas. There's a large load on radiology for diagnostic imaging. And if physicians can train and feel comfortable in imaging in those certain areas, that could take some of the load off the radiologist and improve patient outcomes as a whole. So as far as ultrasound education and medical curricula, there's an increased integration of ultrasound since this handy dandy point of care ultrasonography is so available, and it is very affordable to use. Family medicine, PM&R, neurology, radiology, urology, OBGYN, and emergency medicine have all picked this up as a part of their residency program. Even with this increasing use among clinicians and residency programs, medical school curricula varies in their introduction of students to POCUS. Although suggestions for a national curricula has been made, very little has been provided in the guidance of breast ultrasound. And due to the sensitive nature of this exam, you can imagine how finding standardized patients to perform these on can be difficult. It can also incur additional costs to the program. However, many medical schools do have cadaver-based anatomical education, and this module could prove to be useful in introducing the students to POCUS with these existing cadaver programs. So what does ultrasound at KCU look like? First and second years gain entry-level experience, and this is usually in the areas of cardiac, musculoskeletal, and abdominal ultrasound labs. However, breast ultrasound is not something specifically designated within our curriculum. Considering KCU is a large contributor of primary care graduates, 48.8% of the KCU class of 2022 matched into family medicine or internal medicine. In a 2021 article in JAMA ranked KCU as 9th in the nation, with 40.5% of physician graduates practicing in primary care fields. And according to Schoenborn et al., family and internal medicine providers were associated with the highest rate of screening mammogram referrals. So they are a large proportion of people that help detect breast cancer. Therefore, many KCU students could experience benefit through the enhancement of their future clinical practice from learning how to perform and interpret breast ultrasound images. As far as cadaver-based ultrasound, previous studies suggest that cadaver models have been an effective tool in teaching ultrasound techniques. It's been effective in thyroid, bone fracture, neofusion identification. More specifically, it's been used in breast biopsy, a cadaver-based module, which has also been successful. However, less research has been done in the basics of breast ultrasound. So this is where our aim began. We want to expand upon the current literature and provide data for the consideration of the addition of breast ultrasound into medical school curricula. So now we're going to go into more of a breast overview, the anatomy, ultrasound imaging basics. And it's kind of an adaptation of what I presented to the participants in the study. So you kind of get to see that. So a little bit about anatomy. The breast overall as an anatomical system is not as complicated as other systems. Starting with the chest wall, we do have ribs, and between ribs, we have intercostal muscles. Superficial to that, we have the pectoral muscles. Superficial to that, we have adipose glandular tissue. On the external breast, we have the areolar complex, which contains our areola and nipple. And then we have a series of lymphatics that drain that breast tissue. And those become important in things like malignancy. As far as breast imaging for normal composition, adipose tissue appears hypoechoic, so that's a dark gray. Glandular tissue appears hyperechoic, that's light gray. Pectoral muscle appears as a striped layer, and that's deep to your adipose glandular tissue. Deep to the ribs is an area of posterior acoustic shadowing, and the lungs can be visualized as the deepest layer generally on the imaging that you will receive. And they're a hyperechoic line. So again, that light gray, even to white line. So here's what that image looks like as labeled. So on the most superficial layer, you can see the skin at the top, glandular tissue and fat. So the glandular tissue you can see as a hyperechoic, that gray, almost white appearance. And then the adipose tissue, which are the pockets, which are almost a darker gray, the hypoechoic material. And then the pectoral muscle, which is the striped layer just beneath those two, the glandular tissue and the fat. Beneath the pectoral muscle, there's your rib. And you can kind of see it here as a circular object. Below that, you kind of notice a black void, which is the posterior acoustic shadow. And then as our deepest layer in this image, here are our lungs as the hyperechoic line. Diving more into common breast lesions. So breast cancer, it's the most common cancer in women, excluding skin cancers, second most deadly cancer in women. Cysts are a common complaint that people will present with and a common cause of breast mass. It arises from a larger disease process called fibrocystic breast disease. And the lifetime prevalence of this disease is estimated between 70 to 90%. Fibroadenomas are a solid tumor, mixed of fibrous and glandular tissue. Most commonly, you'll see this in women ages 14 to 35, so the younger side. And it's estimated that about 10% of the world's female population suffers from fibroadenoma over their lifetime. So starting with a malignancy, again, we'll see that hypoechoic, that darker gray material, sometimes with a hyperechoic halo. So sometimes it will appear with the hyperechoic or white halo around it. And just like the ribs kind of showed, a posterior shadow can be seen with malignancies. They're mostly irregularly shaped, and they're vertical and not parallel to the skin, unlike more benign conditions of the breast would be seen. They're not circumscribed, so their borders are very jagged, irregular, sharp, and they can have a stellate or star-like distortion. As far as fluid-filled cysts, they're anechoic or black. Their centers are. They have an area of posterior enhancement. Contrast that to posterior shadowing. Posterior enhancement is a lighter gray, whereas posterior shadowing is a void of blackness, basically. The shape of a cyst is more oval round and it's horizontal, circumscribed, meaning smooth borders. Smooth borders is more of a designation of benign entities. And it's not unusual to find more than one within a single breast. And then for a solid fibroadenoma, you can notice that it's hypoechoic, so it's not as fully black on the inside of it as a cyst would be. The shape is more oval most commonly. It can be lobulated. It's oriented horizontally within the breast tissue, parallel to the skin. And again, usually these are of benign condition, so you'll see like a smooth border in that fibroadenoma. As far as breast implants go, they can be filled with saline or silicone. The placement could be subpectoral or prepectoral. And then a capsule versus an envelope. The capsule is the physiologic response after surgery, where your body makes this dense fibrous scar tissue, sometimes with calcium, that forms around the envelope of the implant. And the envelope of the implant is the actual material that contains the filler. So that filler is the saline or silicone. So again, for placement, subpectoral, that's beneath the pectoral muscle, and prepectoral, that's above the pectoral muscle, but below the glandular tissue. As far as imaging for breast implants, they may look like a large cyst, and essentially they're very common or very similar to other cysts that you would see, but they're a man-made cyst. They're anechoic, so they usually have very black centers. You could see an inverted Oreo sign. So on the most superficial layer, you should see the capsule. Then you should have an area where the black filler is if you're looking at the inverted Oreo here. And that would be like a potential space between the capsule and the envelope. And the envelope itself is that actual covering of the implant that contains the material. You can tell the difference between two on imaging through a step-off sign. There's an artifact created by a lower transmission speed of the ultrasound waves through silicone. So here in the saline implant, you can see the difference between the tissue and the saline implant. There's a straight line as compared to the silicone implant here, where there's kind of the zigzag or step-off sign due to that lower transmission of speed. Now diving more into materials and methods, as far as the recruitment, the assessment slides, lab sessions. There's kind of many moving parts to this, so I wanted to provide an overview, hopefully to break that down in an easier, more digestible format. So COM 2025 and 2026, those are our current first and second years, were recruited for this study. A pre-assessment was provided to the students to take before review of slides and in-person labs. A post-assessment was provided after the completion of slides and ultrasound instruction. And then scores on the pre and post-instruction exams were analyzed using multivariate statistics. As far as our study population, we recruited all first and second years at KCU on the Kansas City campus through student distribution email list and mentions during class. Third and fourth year medical students were excluded from participation. And then I used two resources to guide the creation of this module: the American College of Radiology, which is a widely accepted resource for radiologists in America, on breast imaging, and then Radiology Assistant, which was created by a radiologist for use by residents in radiology and other radiologists for a simple breakdown of how to perform breast ultrasound imaging. And then the slide presentation itself covered the following: the appropriate settings and ultrasonography terms for the butterfly handheld system, normal findings and composition on breast ultrasound imaging, identification of fluid-filled versus solid lesions, and then findings associated with malignancy and breast implant imaging. So on the pre-instruction assessment, it was a 16-question assessment that was provided to participants prior to their completion of the slides and labs. And it examined the following: breast specific training prior to the course, specialty interest, gender identity, and 2 Likert scale questions on relevance of breast ultrasound. 10 multiple choice knowledge-based questions were also on this assessment. And then as far as the cadaveric module goes, we employed 5 formalin-embalmed female cadavers for this study. 2 standardized lesions were adapted from McCreary et al., and that was the breast biopsy study that was presented earlier in the introduction. And that was the fluid-filled cystic lesion and solid lesion. And then 2 standardized lesions were newly added, and this was the malignancy and breast implant. We also had a control for a normal breast without standardized lesions, so participants could run through what a normal breast would look like as compared to the lesions. And back to that anatomical image where the dashed line above the pectoral muscles delineated where I would place the implant or place the standardized lesion. And you can see this purple dot here as a representative lesion. I wanted to place it within the adipose glandular tissue. As far as the breast cyst goes, I used nitrile gloves and I cut through the middle finger and filled with water and then tied off the end, kind of like a water balloon. And then I cut any excess tail off before I implanted it within the adipose glandular tissue. I confirmed it with ultrasound imaging myself to make sure it looked like what it was supposed to look like before I completed this step. And then again, I cut off that middle finger with scissors, and then I filled a syringe with normal milk-based yogurt, and again, tied it off like a water balloon and placed it in that adipose glandular tissue. And then for the malignancy, we had an existing fungating breast mass. So this was taken off fairly early, dissected as a whole piece, and I dissected out a small part of that mass and implanted that mass in the same cadaver on the non-affected side. And then we already had a cadaver with implants. So this one, her imaging characteristics suggested that it was a saline implant that was subpectorally placed. So we could see that stripe layer over the implant, suggesting that the stripe layer being the pectoral muscle was over the implant, so subpectoral. And then we did not see a step-off sign, suggesting that it was saline. As far as the lab sessions went, a total of 15 50-minute sessions with a max of 10 participants were completed from February 20th to 24th, 2023. The participants were instructed to independently review the module prior to the lab session, so they were instructed to review slides before they came in. And during the session, participants were guided through the 5 donor models and asked to identify structures and terms provided in the slide module. And they were also given the opportunity to perform ultrasound. And then this is an image captured by one of the participants of a breast cyst. You can see that anechoic or black inside here and the smooth borders, which I thought was pretty good. Post-instruction assessment, an 18-question assessment was provided, similar to the pre. Questions on this assessment examine the following: 8 Likert scale questions on benefit of and skill confidence in breast ultrasound, 10 multiple choice knowledge-based questions identical to the 10 on the pre-instruction assessment. And then an optional free response section was provided at the end for participants to voice their feedback on the module. As far as results and discussion, a little bit on the participants in their makeup. So there's 104 participants total, 44 in COM 2025 and 60 in COM 2026. Of the COM 2025, 31 were female, 13 were male. And then of 2026, 37 female and 23 male. Overall, you can see that there's a dominant female appearance here in the participants. So 65% were female overall and 35 were male. More gender options were provided on the assessment, but participants answered in a binary manner, male and female. As far as age ranges, COM 2025, most were in that 20 to 29-year-old range. A few in the 30 to 39 and 1 in 40 to 49. COM 2026, most again were in that 20 to 29, 5 were in the 30 to 39, and 1 was in the 40 to 49. So 90% of participants overall were in that 20 to 29-year-old range. Of specialty interest, participants mostly selected surgery, emergency medicine, internal medicine, obstetrics and gynecology, and family medicine. However, you can see that there is more representation. Of note, the next most selected specialties were pediatrics, unsure, anesthesiology, neurology, and radiology. But we have a little bit of representation from most other specialties, which was interesting and neat. Out of 104 participants, none reported previous breast ultrasound training prior to this course. Diving more into the scores, so for COM 2025, the pre versus the post. On the pre, they scored a mean total score of 5.5 on the pre and 8.205 on the post, with a correlation of 0.248 and a p-value of 0.104. A mean increase of a positive increase of 2.705 points was seen. And then moving on to 2026, their pre was 4.767 and their post was 7.467, correlation of 0.251 and a p-value of 0.054, a mean positive increase of 2.7. And then combined, oops, sorry about that, jumped ahead. Okay, so combined, the pre was 5.077 and the post was 7.779 with a correlation of 0.293 and a p-value of 0.003. As far as the Likert scale for the combined 2025 and 2026 cohorts, the pre-assessment contained 2. Breast ultrasound is relevant to my current educational needs, and breast ultrasound is a valuable tool for my future medical practice. And you can see on this Likert scale representation that strongly agree and agree were most commonly selected among these 2. And then as for the post assessment, there are more Likert scale questions, with 2 and 3 being identical to the first pre-assessment Likert scale questions. So again, a strong representation of strongly agree and then agree as well. If we look back, I would like to see more ultrasound demonstrations in future and anatomy lab sessions. And so there was a large strongly agree response to that, as you can see here in the dark purple. And then again, for questions 2 and 3, we'd like to do further analysis, but strongly agree and agreed to maintain over these 2 groups. As far as the comfort level of participants in performing breast ultrasound, agree was more commonly selected than strongly agree, but agree overall was a strong result here. And then as far as the free response, participants were invited to provide feedback on the course with a free response, an optional free response section at the end of the post assessment. And most responses fell into themes of positive feedback and appreciation or thanks noted. So mean score increased in the content knowledge questions on the pre and post assessment, indicating a positive increase in knowledge after completion of the course. COM 2025 started at a higher baseline score than COM 2026, most likely due to COM 2025 having a year of medical school under their belt. Overall, a similar point increase was noted between each class, noting they're signaling a degree of consistency within the course. And as far as the Likert scale questions, most participants answered agree or strongly agree to those items. And students expressed that breast ultrasound is relevant to their educational needs and future medical practice. The incorporation of ultrasound into anatomy lab sessions may be a favorable future learning tool among medical students. Students reported feeling fairly confident in their ability to perform breast ultrasound after completion of this course. As far as limitations, we use formalin fixed cadavers, which are fairly stiff compared to their live patient subject counterparts. The cadaver age, most of our cadavers are in the older range, so above 50, 60, so breast composition changes. Unequal distribution of sample size between COM classes. COM 2025 had less than COM 2026, And then self-selection bias, participants were generally eager to participate in the study based on sign up. As far as conclusion and future direction, overall a net benefit in learning perception was observed. Breast ultrasound should be considered when discussing ultrasound in medical curricula. But the next step to this module will be creation of a skills checklist and observing participants as they perform breast ultrasound to better examine competency and preparedness. And then utilization of standardized patients. So evaluation of these patients within a sensitive exam format would provide the most realistic experience for students. I want to acknowledge the donors themselves. Their sacrifice not only made my research possible, but enhanced the education of our students very directly. And they were very appreciative of that as well. And here are my references. All right, and thank you for joining. Are there any questions?
Awesome presentation, student Dr. Reed, great job. Thank you so much again for presenting in the journal club. As she said, if anyone has any questions, feel free to either raise your hand in Zoom, or if you can't talk, you can type it in the chat and I'll read it so that it's in recording. Looks like we have one question.
Hey, Colleen. Great presentation. I was wondering, you mentioned for future studies and just incorporation into anatomy labs. How do you anticipate that would be done? Would you do that with first years during their actual anatomy dissection labs, or kind of how you did it sort of outside of the lab time?
So there are two ways. For my research project, I was imagining a medical school curricula standpoint where they could incorporate more into anatomy lab sessions. I've seen other schools have ultrasound interest groups. So those are groups outside of curricula that can form and do ultrasound in a cadaver or non-cadaver format. So I could see it being a viable option in that as well. But for this project, I was imagining curricula. But other extensions of this use could be for groups outside of curricula.
Thank you.
Any other questions, comments?
I got a quick question for Colleen. Great presentation. So I know you and I have kind of both talked about kind of wanting to go into kind of a women's health kind of career. So I'm a little biased in, the fact that I think there should be more ultrasounds, and I think this would be a great avenue to do that. Have you looked into any hurdles that schools that did not have this already implemented, what hurdles they have into actually getting it from, the starting point to actually having a full-fledged, process for doing something like this?
I did. Cost was one of them. And instructors was the other. So I noticed a lot of schools were saying that they had a lack of instructors that felt comfortable or had the time to teach ultrasound. But opening it up to students and training them and having them have a level of competency before they go in and train other students is a viable option to overcome that. But I would say the instructor aspect was the biggest hurdle that I've seen, that instructors either didn't have the time to up their training to match the ultrasound needs or skills, or that they just didn't have time in general.
Cool, thank you.
Mm-hmm.
I just want to take a second and acknowledge Colleen's innovation in this, just because, one, it's a great project, but also to recreate sort of synthetic things for the comm students to evaluate, and then including packaging her breast mass in the same donor so that we didn't have issues with sharing of anatomical material. It was, I just thought, really great, and a really great way to think of the project, but then also make it doable under the constraints that we have to operate in within the lab, with also being cognizant and respectful of the donors as much as possible. So I thought it was really, really innovative and a great idea. So kudos to you, Colleen.
Thank you. Everyone has nitrile gloves and water and yogurt.
I mean, and inexpensive, you know, I mean, a lot of times we get into trying to recreate things and it's so costly. And in this context, it you know, is very affordable. And you could, in theory, make multiple cysts to use at multiple stations, and it would not be a huge outlay for any institution. So I think that's really great.
Dr. Creamer, do you have a question?
Yeah, and I may have missed this, but sorry, my phone is going out. I may have missed this, but did you say that you're going to try to publish this?
Yes.
Great. I think this was a really great study, and I really like the way that you went about setting it up. And it's really, I may have to have a chat with you about how to recruit participants, because to get that many students involved was really great as well. So I just wanted to compliment your study, and also you know, really encourage you to publish this. I think it would be really interesting to other folks as well, how you went about this.
Thank you. I'm hoping the same. I hope other schools and institutions, it perks their interest. And as far as the participants went, a lot of mentions and recruitment and emails went into that. I think I had an advantage that I was an anatomy fellow, that I had. That's probably why I had more come in 2026, that they knew me, so they saw my face, they could talk to me about it, but they all seemed fairly excited to try something new.
Awesome. Great discussions, great comments. Anyone else? Any questions, comments? If not, thank you so much again, student Dr. Reed, for speaking in our journal club. And yeah, just to reiterate what has been said over and over here and in the chat, wonderfully done, wonderful presentation. This was a really interesting project, and you did a really good job presenting it, and good luck with the potential publication. Thanks again, and thank you everyone for being here for today's presentation as well.
Thank you.